All right, burns. So it's important for us to understand normal. I say it a lot because I think a lot of times students want to memorize, and then you get into a stressful situation, one, as a student in a test, or when you're out in clinical and you're working with a patient and you're trying to go off your memorization, and during a stressful situation, your memory doesn't always work with you. So it's important to understand normal, because if you understand normal, you can figure out abnormal real easy, okay? So you want, with skins, when we talk about burns, it's important for us to understand what's happening at each layer, because then you can kind of get an idea of, like, when you're trying to classify the depth of a burn or what might be happening based on the depth of the burn, it's easy to figure out because you know what's happening. So the epidermis, which is that top layer, all right, it's replaced every 30 days. And it's super, super thin, thin as paper. It's our protective barrier, so it allows, make sure that nothing comes in. It holds our fluid and electrolytes and regulates our body temperature. So as we talk about burns, and we have different depths of burns, if we have a burn through the epidermis, are our patients going to be able to control their body temperature as well? No. Are they going to possibly have problems with controlling fluid and electrolytes? Yep. Are they at risk for infection because their protective barrier is gone? Yep. So again, if we know what these normals are, we can already in our mind be thinking about what's my patient at risk for. When we get to the dermis level, that's more our connective tissue, our blood vessels, our sweat and oil glands, our hair follicles, and our nerve endings. So think about this. If I have a burn that's gone through the epidermis and now into the dermis layer of the skin, and my nerve endings are exposed, you think that's going to be kind of painful? Yeah, it's super painful for them. If we're exposing sweat and oil glands, that's why we have burns that are super, I hate this word, moist and wet, right? At that level, okay? And as we go into the subcutaneous, that's where it's our heat insulator, our major vascular networks, the fat nerves. So as we go all the way into the subcutaneous tissue, we've the nerve endings we've burned off. If we've already gotten all the way to the sub-Q, and that depth of the burn includes that, then it's no longer painful because we've kind of burned everything off, right? So it's an actual worse burn, but because we burned through it, the patient may not have the same signs and symptoms. When we're talking about partial thickness burns, we're talking about anything that involves the epidermis and the dermis. And when we're talking about full thickness burns, we're talking about burns that include the subcutaneous tissue. All right, so basic review, everyone got that? All right. So when we're talking about burns, there's a lot of different ways we talk about them. One of them is what caused the burn. All right, these are all your different causes. It can be thermal, chemical, electrical, radiation, or cold. Whenever we think of a burn, we think of just fire, that's what burns, but there's a lot of other things. Obviously, thermal's the most common one, but. And our goal, it doesn't matter what the type of burn is, our goal is to stop the burning process. Because as long as we continue to have a burn continue, whether it's an electrical burn, a current going through the system, or cold, where we get frostbite, when we think of that, that's a burn. As long as we continue to have that burn happening, we're going to continue to have damage to the skin and at the cellular level. So our first action as the nurse is to make sure that we stop the burn. Thermal injuries, like I said, are the most common. They can be caused by a flame, electrical flash, a scald injury. That's really common. We're talking about toddlers during this age group, and that it fits well with burns because what are toddlers doing? Exploring their world and reaching for everything, right? And it's very common for them to pull down like a pot of boiling water or reach for a cigarette or, as they're exploring. Hot objects like a heater or a cigarette, or inhalation injuries, so gas or smoke. Inhalation injuries are particularly difficult. This is when they inhale the hot or noxious chemicals. And a lot of times we don't, they've been in a burning building. Have you ever guys watched that show, This Is Us? Has anyone seen that? So the big episode where they revealed how the dad died is basically a fire broke out in the house. And they were all sleeping. A fire broke out in the house. They woke up to smoke. And the dad went in and out several times because he got his kids out, he got his wife out, and then he went back in and got his dog out. I think they went crashing through the top window or something, if I remember correctly. But so he never actually got a burn on his skin or face or anything like that. But he did inhale all that hot air and gas. And when that's happening, you don't really see a burn in the outside, but think of that tissue, think of that mucosa inside your mouth and along your trachea. That's super sensitive. And when you inhale that hot air, it gets burned. And you don't see it on the outside, but those chemical changes, those physiological changes are still happening on the inside. So it's really important that as you're getting your history and you're doing your physical exam, you look for signs and symptoms that are going to kind of trigger, oh crap, they might have had an inhalation injury. Because if they have had an inhalation injury, they're at really high risk of their airway closing down. So they could have soot on their face, singed nose hairs, wheezing, hoarse voice, and they're at risk for CO2 poisoning. We intubate them to protect their airway. So we treat them, the biggest thing we're going to do is intubate them to protect their airway. So because we're going to be talking about the different phases of a burn, and when we talk about those different phases, you're going to find out that during the emergent phase, they have massive swelling and fluid shifts. And because of that, you'll see someone that's completely normal, that just maybe has a little soot on their face, maybe a little singed hairs, maybe a little wheeze, and then an hour or two later, you won't even be able to recognize them because there's going to be so much swelling. So if we're at risk for a inhaled thermal injury, they need to be intubated. We need to protect that airway because once it swells, then you'll have to either trach them or, do something more emergent because you won't have control of that airway. We also need diagnostics. We need and I always have to make sure I say this right, our carboxyhemoglobin level. And basically it's your CO2 level, okay, or CO level. And most fatalities that happen are because either they aspirate or their airway closes down or because of their elevated CO levels, their carbon dioxide levels. And what happens is that our red blood cells contain oxygen, right? And with that, hemoglobin has a higher affinity for CO than O2. So when you put a pulse ox on somebody and you're measuring that, all you're doing is saying that it's 100% bound hemoglobin. It does not tell you what that hemoglobin is bound to. So when you have a pulse ox on them and you're like, yay, they're satting 100%. No, all you're saying is that their hemoglobin is 100% bound to something. If they've been in a burning building or have any risk of inhalation, then that hemoglobin could be bound to carbon dioxide, okay? And so can you use carbon dioxide? No. That's what you're supposed to be getting rid of, right? So now you think your patient's all good to go because they are satting 100% and they look just fine, but you've just given yourself false security because they're not really 100%, they're just 100% bound to CO2, if that makes sense. So the only way to really distinguish whether you have a true O2 sat reading is to get this carbon oxide hemoglobin level and make sure that it is not elevated, all right? Basically, any victim that is found in an enclosed space with a fire, they're at risk for the inhalation injury and they're at risk for CO2 poisoning. And those should be high red flags for you that I need to get this carbon oxide hemoglobin level and I need to protect my airway right away. So this is a patient. This is them when they came in. And even this is a pretty bad looking burn. But 1 hour later, you can see the massive amount of swelling that can happen, okay? And it happens pretty darn quick. So this is why it's so important to protect their airway. So again, protect the airway. And if they're in a closed area, they should presume to have an inhalation injury. All right, so that was thermal injuries. Chemical injuries, they can be caused by either acids, bases, organic compounds. Everyone thinks acids are harder to control, but it's actually your alkalotic agents that are harder to manage because they keep burning even after you've, gotten the material off of you. Basically, the clinical manifestations is tissue destruction. So, I don't think I have. So they have tissue destruction. And even when you remove the agent that they're being burned with, that tissue destruction can occur up to 72 hours later. So if our number one goal is to stop the burn, what do you think our treatment's going to be? If they're getting burned with a chemical, and we got to get the chemical off, right? Okay. Now, are you going to sit there and rub it off? No, because you're just going to rub that chemical into their skin. You need to lightly try to brush it off. Are you going to lightly brush it off with your own particular hand? No, please wear a glove or some kind of protectant agent so that you don't burn yourself. And then you're going to brush it off and you're going to dilute it. So you use copious amounts of water to flush it, to dilute it. Again, the biggest thing though, you don't want to rub it because you don't want to push it deeper into the skin. All right, so thermal burns, chemical burns, then there's electrical burns. And electrical burns are typically either from a power source or from lightning. And when you have a burn from an electrical source, you're going to have a burn on the outside typically, okay? You're gonna have a burned area of skin. So you're gonna have some tissue damage, but specific to electrical burns are all these other clinical manifestations. So you'll have the burn itself, and you'll have either one burn or two burns. Sometimes lightning or the electrical source, it will enter and exit through the same spot, or it could enter one spot and exit a different spot, okay? I tell a story, so when I was, because I like to tell stories, I'm sorry, y'all. But when I was about, 10, 12, I was younger, I had a waterbed. I mean, who had a waterbed growing up? Anybody? It's like the coolest thing ever. I know. Yeah, some of you are way too young to know what even a waterbed is. But a waterbed was so super cool, y'all. Okay? I grew up in a teeny tiny home. It was less than 1,000 square feet. There were 6 of us. and we had to move the waterbed, and we couldn't move it through the house, so we took it down and we moved it through the front window and like into another window, okay? And of course, my parents, who were happily married for 40 years, caused the biggest scene out in the front yard. Like, all the neighbors pulled up the lawn chairs and had a beer and were watching my parents argue it out as they moved this waterbed. So big scene, arguments, all this stuff. So later that day, we're all hot, we're sweaty, and my dad goes for a swim, and he goes in the pool, and he comes out of the pool, and he walks into the house, and he fell over. And he was just, actually, he stood there for a minute, and he just sat there, and his eyes were open, and he made this kind of god-awful sound, and he just, like a moaning kind of sound, and then he eventually fell forward, and he fell down. And, we called 911, so now all the neighbors think that my mom has abused my dad, or that, like, she's out to murder him or something, because they had such a fight, whatever. And if anyone knew my parents, my dad was, like, super docile, and my mom was, like, super extroverted. So, ambulance is there, they take him out, our neighbors assume my mom has hurt my dad. Emergency vehicles have assumed that my dad has had a heart attack. And so they're bringing him in and they're assessing him, and some very astute nurse noticed a burn mark on the bottom of my dad's foot. And he had gotten an electrical burn. So we had, my dad worked in construction, and so he had some of his buddies come and cut a door into his bedroom so that he could have direct access to the backyard, okay? And that's how he would come in and out of the pool. And when they did that and they wired, they cut through some wires, they didn't cap off the wire, and so, or they didn't do a great job. So every time my dad would open and close the sliding glass door, they ended up fraying open that wire. And then the entire metal frame became electrified. So when he stepped in from being wet from the pool and stepped on the metal frame, the electricity and the water created a perfect storm, and he got electrocuted. So, but had we not known, then had we not found that burn mark, we probably would have just thought he had a heart attack. But it was, it's hard to find because it was on the bottom of his foot. And so he said that when he hit it, he could automatically feel his whole body tense. And he said it felt like someone was just squeezing him constantly. And he was trying to tell us what was happening, but couldn't. And he said all of a sudden he mustered enough strength to push himself forward off and break the current. So the current was just going through him and coming in and out of that same spot in his foot. So thank God my dad's a pretty big guy. So a win for Big Macs right there. And because of his size and the electrical current, he had minimal damage. But this is why some of these things can happen, because imagine your whole body contracting like that. Cardiac arrest, it's electrical activity. So it can mess up the electrical activity of the heart and cause a cardiac arrest. There's always like that entrance and exit wound, bone fractures because of the contractures that they sit in, depending on how long and the degree of the voltage. They can get C-spine injuries because when they do break the current or from the contractures or from falling, they can get a C-spine injury. Myoglobin, so basically what happens is that whenever you have muscle breakdown, you get myoglobin released, all right? And so that is a lot of contracting happening in the muscle. So it's basically like you're doing a bunch of biceps or a bunch of something. And so the muscles are really working and breaking down, so they produce a ton of myoglobin that then gets spilled out into the urine. They develop an acidosis, so because of the electrical part of it and it going through the body and burning, they have a lot of other aspects that have it. But we got to go home and tell all the neighbors that my mom did not hurt my dad and that it was just shoddy work by the construction people. So, but it was a story that people still talk about in the neighborhood. Treatment is always based on the clinical manifestation. So for my dad, thank God, he basically had the burn wound and he had no other long-term effects. So we treated the burn, we monitored him in the hospital for a day, and he went home and he was fine. Obviously, they have other things like a cardiac arrest you're going to treat as he had a heart attack. If they end up having any kind of injuries, you're going to treat the injuries specific to that, in addition to treating the actual wound itself. Then you have radiation and cold. Radiation is what we think of sunburns. You can also have radiation burns as well. Think of people that have cancer and they're getting radiation treatments. Oftentimes we have to do really good skin care because the area that's getting radiated does get broken down. I'm sure everyone here, it's Florida. Has anyone never had a sunburn? Yeah, I didn't think so. Everyone's always had at least like something, right? And typically with radiation, the clinical manifestations, again, there's that tissue damage. Obviously, the more you get exposed, the worse the tissue damage is. And we're going to talk about those characteristics in just a second. But they tend to be localized, your clinical manifestations. So with radiation therapy, you have a burn to the skin right where radiation is happening. If you're sunbathing, wherever's exposed is going to be burned, okay? So, and they don't tend to have any other additional symptoms like electrical burns or thermal burns. And then cold, people always think of burns hot, but obviously cold can also cause burn, like a frostbite. They tend to also be localized. But because of the coldness of it, you can get, this says peripheral vasoconstriction, just in case you can't see with the little hand. The peripheral vasoconstriction, because everything's shunting away, all right? They are at higher risk for some cardiac dysrhythmias, but that's more related to the cold than anything else. And the big thing is that we want to rapidly rewarm them, and we don't want to rub or shake. Everybody, what do you do when you're cold, right? You rub your arms, which is okay with you when you're just a minor chill. But if you have true frostbite, if you sit there and rub, you're going to break up those ice crystals or ice, and you're going to be rubbing them in the skin, causing more damage, all right? So you want to rapidly rewarm them with warm water, blankets, those type of things. So those are all the causes. All right, so we know what caused a burn. Now we can talk about the characteristics of the burn. How do we describe it? So you have this chart in your PowerPoint, so you don't have to copy it down. Again, the writing of it just helps kind of reinforce it in your brain. So the first thing we do when we talk about a characteristic of the burn is we talk about the depth of it. There's your tip. So when we're looking, again, at superficial partial, moderate partial, or full thickness, right? Again, remember that, picture of the layers of the skin, okay? It's what does it involve? So with a superficial partial, it's just the epidermis, just the top layer. When we get to deep partial, moderate to deep partial, then we're looking at the epidermis and the dermis. And when we're talking about full thickness, it's all the layers. It includes that subcutaneous level. So think about it. If it's just the epidermis, what is it going to look like? It's just that top thin layer. So think of a sunburn, right? Kind of bright pinky, maybe a little red, but not a whole lot of damage. Once we get into that dermis, remember we said that in that dermal layer, that's where the oil and sweat glands are, that's where we have vessels, that's where we have nerve endings. So these are going to be really shiny and wet, really red. However, as we keep going down and we've burned through that epidermis, we've burned through the dermis, and we're in the subcutaneous tissue, a lot of people think, oh, look, it's just white or dry. That's okay. Actually, that's really bad. All right? So everyone thinks that the real red, moist, weepy wound is the worst. That's actually not as bad. When we get into that subcutaneous and we've burned through the epidermis and the dermis and we are now a waxy white burn, that's significant damage. Blisters. You don't tend to get many blisters when you just peel off the epidermis. Remember, the epidermis is that thin paper, okay? So if you peel off like a piece of paper, do you really get like a blister? Not really. Sometimes you're peeling, think of that paper peeling, that epidermis peeling off, because it gets replaced every 30 days. So you're just peeling off the old epidermis while new epidermis is growing in. When we get to more moderate to deep partial thickness, again, oh, I hate that word, moist, weepy, you get blisters. And once we've burned through all layers, there are no more blisters. Superficial burns, just the epidermis, they're a little tender. Anyone who's had a sunburn says, if I touch it, it hurts, but otherwise I'm okay, right? So not a lot of pain because there's not a lot of nerve endings right there. But if we get into the dermis, it's really painful, okay? Because they have opened up nerve endings. As we get down to full thickness, again, we've burnt through, right through those nerve endings. There's not pain, you know? And a lot of people think, oh, it doesn't even hurt them. It's white, no big deal. It's kind of a bad sign because it means that they've had, again, significant damage. Obviously, the more significant the burn, the longer it takes to heal. So a sunburn takes a couple days. If you have something more significant, it could take about a month or so. If you're looking at full thickness burns, then you're looking at something that requires months of treatment. And oftentimes, because they've burnt through all the layers, they require skin grafting. They're not going to heal on their own. And then examples, pretty much anything that we talked about, any of the causes of burns can really much cause any degree. The degree of the burn, you know, how deep it is depends on how long you're exposed to it, right? If you just get like a flash of fire and you're able to, you know, you get flashed with fire and you're able to put it out, you might have something minor, but if you sit in a fire, it's going to be longer, right? So it gives examples, but really any of our causes can cause any type of this. It just, again, depends on the length of the exposure, for electrical, the degree of the voltage, if it's a chemical, how long, what type of chemical it was. So really anything can cause any of these depending on all those other factors. So then we have to tell, so if you are working at a burn center or you're working in any kind of emergency room or at a hospital and you get a patient that's a burn and you're either referring them out or getting them, they're going to want to know these things. Tell me the depth of it. So you're going to say, I have a superficial or I have a full thickness burn. And then they're going to want to know over how much of the body surface area. And what we do is we use the rule of nines, okay? So that rule of nines tells us the extent. It's a quick way of measuring. And we use what's called the palmar surface. So everyone thinks like, sometimes when you guys read it in your book, you get confused because it says the palmar surface. So you think just the palm of your hand is what's being measured. No, this is your palmar surface. So it's your use of your whole hand is typically 1%. Okay, so if you just needed to quickly do it, you could use your hand, and that's about 1%. What you have to know also, I love my little dude. Ready? Here he is. He looks like he has like edema, right? So basically when we talk about the rule of nines, everything's going to be 9. So the head is 9%. So if you burn your head, it's 9%. That's your whole head. If you just burn your face, it's 4.5. If you burn the back, it's 4.5. The whole head is 9%. And you will see questions on your test and on NCLEX that say, you know, so-and-so dude was exposed to a fire and his right side of his front face and his right arm were affected. So then you know 4.5, 4.5, half of 4.5, they do want you to figure out. But so you have to basically know the rule of nines, but oftentimes it's not going to be as easy as just, what is, you know, how much is your head worth? 9%. They're not going to ask you questions like that. They're going to ask you how to figure it out, okay? So 9% for the whole head, 4.5 in the front, 4.5 in the back, posterior, anterior. 9% for each arm. Again, 4.5 on the front, anterior, 4.5 posterior. Your trunk is going to be 18%. That's 18 on the front, 18 on the back. Think about it, your trunk's a pretty significant area, right? Your groin is 1%, and your legs are 18%. 9 on the front, 9 on the back. So if I was to ask, you have a patient that burned the half their leg, half their right leg, and groin area, how much are you looking at? So if they burn just their leg, the upper half of their right leg and their groin, 5.5%, okay? Because think about it, if the whole leg is 18 and the whole front is 9, I'm burning only half of my front, so 9 divided by 2 is 4.5, and I'm adding the 1%. That's where I get 5.5. Okay? Do you see where it can get confusing?
Yes.
Okay. So that's why I say, I know all of you are looking at me now, like you want to.
I have a question. What's the...
Now I'm going to show you PD, but you don't need to know PD, okay? Your NCLEX and your test will focus on adults. I just want you to be aware, because you are going to go to hospitals, and if you work at Tampa General is a burn center. I worked there for 5 years in their PICU, and we did burns there. So if you are over in that area, you might see them. But so with a PD, basically the biggest difference is pediatrics. What do we talk about? They've got big old heads, right? So they're like, and then they've got little legs. So everything is the same, except for the head has a much higher percentage and the legs are shorter, okay, or less percentage, I should say. Basically, as they grow, we take the percentage off the head and add it to the legs. You don't have to know how to do that. You don't have to figure it out. It's just something to think about, that if an infant or toddler has a burn to the head, it is a much more significant area for them than it would be for an adult, okay? All right, does anyone have any questions regarding the rules of nines?
For the chart, for healing, moderate.
All right, location matters, all right? So they're gonna not only ask you the depth of it, so this is a full thickness burn on 18% of the trunk and partial thickness on 9% of the arm. So they'll ask you the depth and the extent, but also where did they get burned? Because where they got burned matters. There are things that will automatically send you to a burn center. And there's a percentage of burns, and I honestly forget it offhand. I think it's 20%. Your hospital will know. If they have a certain percentage of their body burned, and you don't need to know it, then they will automatically send you to a burn center. However, even if you don't meet that certain criteria, the 20%, whatever it is, if you have a certain part of your body burned, even if it's just 1%, they will still send you to a burn center because they're at higher risk. And those are the things like the face or the neck, because imagine if we're going to talk about this with treatment of burn. If the neck is burned and we have scar tissue, it could restrict your airway, right? If there's burns to the face, then we're worried about inhalation injuries. If they have circumferential burns, so burns that are around the chest, again, it can cause a compartment syndrome and cause it, make it difficult for them to breathe. Anything that hands, feet, joint areas, if they burnt themselves over a joint, because they're going to need possible more treatment because that area is tighter. And also if they burn the ears, nose, genitalia, then they typically go to a burn center because there's higher risk of infection. Typically they need more things like plastic surgery. They need more other interdisciplinaries involved, like physical therapy, occupational therapy. They may need speech therapy to help them eating if they burn their face. So they just need more care. So even though they may not meet the percentage to go to a burn center, sometimes having a small burn on these particular locations can be worse because they have a whole nother set of problems that they have to deal with. And they just need a whole team to help take care of them. Risk factors for patients. Basically, if they're younger than 4 or older than 65, we worry. Or if they have any other disorders or chronic illness injuries. Again, we've talked about kids, they just don't compensate as well. The elderly don't have the reserves. And if you have other things that are basically taking your body's attention, it's really hard for your burn to heal when you're fighting diabetes, right? With diabetes, you're already at risk for infection. So if they have those risk factors, it's important for you to communicate that with the care team because it's going to help determine their plan of care. So all of these things are going to help tell us the characteristics. We know what caused it. We got to figure out what caused the burn. That's going to help guide treatment, and we need to know the characteristics of the burn so we can guide treatment. All right, we're now going to go into phases of burn care. I'm going to do the first phase really quick because it literally is really quick. And then we'll take a break and go into the other phases. Now, this is in general phases of a burn care, okay? And when we're talking about burns, we're talking about patients that are coming to the hospital. Now, do these phases happen to, like, if you've gotten a sunburn? Yes, but to a lesser extent, right? We're talking about patients that are severely burned enough that they're in a hospital setting, and these are the things that we would need to be doing our nursing care management to ensure proper care, all right? So the first phase of burn care is pre-hospital. So this is care that's delivered at the scene. And what is the first thing we're going to do? Oh, somebody was listening. Thank you. Stop the burn, okay? Stop the burn. So it could be, let's say you're at home. If you, I just did this the other night, or Labor Day, we were making peppers on the stove and somebody took the metal tongs and left them on, and I picked it up and I picked the tongs up to pick up peppers and I burnt my finger. What's the first thing I did? No. I put it under water, okay? I put it under cold water. I stopped the burn. If I have a chemical, I'm going to be diluting it and brushing it off. If there's an electrical burn, I want to stop that electrical current. If there's a thermal, I'm going to stop it. If it's frostbite, I'm going to rewarm. So whatever it is, I need to stop the burn, whether it's minor or severe. Always ABCs are next, right? Airway. We've got to protect that airway, especially if there's an inhalation injury. We treat any injuries that would need treating. So let's say it's an electrical burn and they fell and we're worried about a C-spine injury. As soon as we secure that airway, we're going to make sure we, protect the C-spine so that we don't have any other damage. Basically, we want to prevent any further damage, any further injury, I should say. And then the big thing is we're going to begin fluid resuscitation, okay? Because we're going to talk about this in the next phase, the biggest thing that happens is that they have a massive fluid shift and they're at risk for shock. So the Parkland formula, which is, I'm going to be honest, a little bit confusing, that NIPS is going to go over, gets initiated as soon as possible because we give them so much fluids. Has anyone worked a burn? Okay, sometimes they'll be like, oh, I was amazed by because it's liters and liters and liters of fluid because there's so much fluid shift. So we're going to go ahead and begin fluid resuscitation. So that's pretty easy, right? That's the first phase. The next phase is going to be a little more intense.